All right, good morning everyone. It's my great pleasure to introduce Dr. Daniel Gero. Daniel joined our department about 3 years ago as a bariatric research fellow and is about to defend his PhD thesis in spring next year. He's in his 7th year of residency and will talk about hiatal hernia repair, reflux disease in the context of bariatric surgery. We're very much looking forward to your talk, Daniel.
Thank you very much for this kind introduction. Good morning. Happy to be here today to give an overview on hiatal hernia, reflux disease, and bariatric surgery. First of all, I'd like to emphasize that both GERD and obesity are chronic diseases, and the role of surgery is reserved to the treatment of the tip of the iceberg, while the vast majority of patients may benefit from conservative therapy, including pharmacotherapy or lifestyle modifications. So who should we operate? According to the Swiss Society of Morbid Obesity, patients with a BMI over 40 qualify for bariatric surgery, as well as those who have a BMI over 35 with obesity-related comorbidity. In the near future, probably this criteria will be expanded to patients with BMI over 30 with a type 2 diabetes mellitus. Regarding GERD, according to the latest conference report of the European Association of Endoscopic Surgery, patients with continuous reduced quality of life, persistent troublesome symptoms, and progression of disease despite adequate PPI therapy are those who may benefit from a surgical anti-reflux therapy. So today we're going to talk about the epidemiology of obesity and GERD, the anatomy of the gastroesophageal junction, the preoperative workup which needs to be done when we are planning a procedure to treat obesity and GERD concomitantly, the surgical options, and at the end I would like to flesh up some innovative surgical procedures. It is needless to talk much about how prevalent obesity is in the world. In the last 4 decades, the prevalence have tripled, and it is present not only on Western countries, but in the third world countries such as South America, Central America, Middle East, in Australia. According to the World Health Organization, we talk about obesity above BMI 30, severe obesity above BMI 35, morbid obesity above BMI 40, and super obesity above BMI 50. Regarding the prevalence of GERD, data is a bit more complicated to collect because the definition is based on the self-report of the patients according to the Montreal Consensus of the definition of GERD. So GERD is a condition which develops when the reflux of gastric content causes troublesome symptoms and/or complications. In industrialized countries, the prevalence of GERD is between 1 and 20%. However, you can see that there are some countries where the prevalence is above 25%, for example, in India. An important paper published in 2006 in New England Journal of Medicine, it has been shown that there's an association between BMI and reflux symptoms. And interestingly, it is already present in the healthy range of BMI between 20 and 25. And actually, obesity is the main risk factor for the development of GERD together with tobacco. So that would be my first question to the residents. What is the pathophysiological driver of obesity to trigger GERD? Good. So obesity increases the frequency of esophageal motility abnormalities. It increases the postprandial transient relaxation of the lower esophageal sphincter. It increases intragastric pressure. Furthermore, it adversely affects the outcome of anti-reflux procedures. And there's more and more data showing that a failed reflux procedure in an obese patient may benefit from a conversion of fundoplication to Roux-en-Y gastric bypass. Next, I would like to talk about the anatomy of the gastroesophageal junction. The esophagus comes from the thoracic cavity to the abdominal cavity between the diaphragmatic crura above the aorta. And this is a very important region because it represents the physiologic anti-reflux barrier. For this barrier to be optimal, the lower esophageal sphincter needs to be supported by the diaphragmatic muscles, and a small portion of the esophagus must be in the intra-abdominal position. This red line shows the so-called His angle, which is the angle between the cardia and the esophagus. And when the angle is acute, there is this physiologic anti-reflux valve that protects esophagus from acidity. If the angle becomes flat, there is a higher chance for patients to develop reflux. On this figure, you can see that the sliding hiatus hernia can completely disrupt the physiologic anti-reflux barrier by pushing the lower esophageal sphincter to the thoracic cavity and losing the support from the diaphragmatic muscles. Further, in this herniated part of the upper stomach, there is constantly acidity that can be in contact with the distal part of the esophagus. Beyond the uncomfortable symptoms of GERD, there might be also histologic changes due to this disease. As you can see in this endoscopic view, patients are prone to develop esophagitis. They might have chronic ulcerations and may develop Barrett metaplasia, which is a precancerous state. So now I'd like to talk about preoperative workup. When we are planning surgery for patients with obesity and GERD, it's important to perform preoperative gastroscopy. This can confirm or identify a hiatal hernia. It is allowing us to perform biopsy for suspect lesions and also to look for the presence of Helicobacter pylori, which needs to be eradicated before surgery, or to identify gastritis. Next, it is also recommended to perform a 24-hour pH metry, which can be done on an ambulatory basis. Patients need to hold a tube in the esophagus, which is connected to a variable device, which records data continuously. This allows us to have an idea on the frequency and severity of reflux and differentiate acid reflux from biliary reflux. Esophageal manometry is also an important item of the preoperative workup. It may identify motility dysfunction, it may identify the position and strength of the lower esophageal sphincter, and also identify transient relaxation of the lower esophageal sphincter, which is increased in obesity. It is also recommended to perform a barium swallow, or the so-called upper GI series, which can help to confirm hiatal hernia, supports the planning of the surgery, and can differentiate sliding hiatus hernia from paraesophageal hernia. In patients who are symptomatic from GERD, after bariatric surgery, abdominal CT is often part of the preoperative workup. Here, a pathognomonic feature of sliding hiatal hernia is the presence of the staple line above the diaphragmatic crura. Here in this picture under, you can see that part of the pouch is herniated. So what are the surgical options? Regarding GERD, an evidence-based approach to treatment of this disease published in JAMA Surgery 3 years ago states that laparoscopic fundoplication is the mainstay of surgical therapy with Roux-en-Y gastric bypass reserved for morbidly obese patients presenting GERD. Regarding bariatric surgery, the armamentarium of surgical procedures is quite wide. When we look into what happened in the last decade, we can see that there is a very steady increase in the total number of procedures performed in the world. And since 2014, interestingly, sleeve gastrectomy became the most widely performed procedures, while Roux-en-Y gastric bypass is the second most frequently performed procedure. We can also see that adjustable gastric banding has almost gone completely out of the business, and there is a slight increase of omega loop gastric bypass. This data was collected by the self-report of surgeons who are member of the International Federation of Surgical Obesity Association, so it might not be 100% accurate. When we look in the data from Switzerland, which is derived from the Bundesamt of Gesundheit based on administrative database containing CHOP codes and ICD codes, we see that trends in Switzerland do not mirror trends of the world. The last 6-7 years, Roux-en-Y gastric bypass was the most frequently performed bariatric procedures. And nevertheless, we can see that this blue bar plot shows the increase of sleeve gastrectomy over the last years. Interestingly, the uptake of sleeve gastrectomy in Switzerland is not homogeneous. In French-speaking and Italian-speaking Switzerland, there's kind of a reluctance to perform sleeve gastrectomy, whereas in central Switzerland, sleeve gastrectomy became quite popular. Performed a logistic regression to identify factors of primary bariatric procedure decision, and actually GERD and hiatal hernia are significantly influencing the choice of a gastric bypass and decreasing the choice of sleeve gastrectomy. And this choice observed in a Swiss database may mirror data coming from high-quality evidence, including randomized control studies. I would like to present some data from the SMBOSS trial. It is important because our department participated to this study. out of which the last study was published of the 5 years result in JAMA Surgery last year. This study included over 200 patients with a primary endpoint weight loss, but in this publication, there's also some data on secondary endpoints, including gastroesophageal reflux disease. And here it has been found that Roux-en-Y gastric bypass performs better in patients who had GERD at baseline, had a remission in 60% of cases, which happened only in 25% of cases after sleeve gastrectomy. And also interestingly, it was found that asymptomatic patients at baseline had sometimes developed de novo GERD, which happened 30% of cases after sleeve gastrectomy and only 10% of cases in the Roux-en-Y gastric bypass arm. However, in this study, the postoperative definition of GERD was liberal. It did not obligatorily include pH metry. And actually, the entire medical literature, there's a paucity of data regarding pH metry after bariatric surgery. There's a recent publication from Bern that included 47 patients who were symptomatic of reflux after Roux-en-Y gastric bypass to undergo pH metry. And I would like to emphasize two interesting findings of this study. One is that only 60% of these reflux patients had an acid reflux. And another interesting finding was that the presentation was a bit atypical. Less than 20% of the patients complained of heartburn and regurgitation, while the majority of patients had obstructive symptoms and pain. pH metry after sleeve gastrectomy is also scarce in the literature. A group from Greece had a different approach and included 12 patients who were asymptomatic at baseline, who underwent a pH metry, and then they repeated this exam 1 year after surgery. What they found is that the percentage of total time with a pH under 4 increased from 4% to 13%, and the total number of reflux episodes almost doubled. The effect of bariatric surgery on Barrett metaplasia is shown in the next two slides. Roux-en-Y gastric bypass has been shown to be able to achieve regression in patients who had Barrett's metaplasia and baseline in around 42% of cases. And the opposite was observed after sleeve gastrectomy. In this study, 17% of patients undergoing sleeve gastrectomy presented a Barrett's metaplasia 5 years after surgery. Therefore, the authors of this study state that Barrett metaplasia after sleeve gastrectomy is a possible underestimated long-term complication. The worst complication after bariatric surgery is development of carcinoma. There are some case reports showing that this may happen after sleeve gastrectomy, but also after gastric bypass. The advantage of gastric bypass here is that the excluded stomach is available for the reconstruction of the conduit after esophagectomy. So my second question to the residents would be, what may be the explanations of the beneficial effects of Roux-en-Y gastric bypass on GERD symptomatology? Yes, please.
The deviation of general juices from the stomach and maybe also biliary tract. Generally, reflux symptomatics just because the surface is smaller, and obviously the connection of the biliary tract is more proximal. Oh, sorry, distal.
Yes.
I think the acid-producing cells in the stomach are mainly found in the corpus, and this one is removed, right? So it should lower the acid in total.
Yes, correct. So, as you said, there's a deviation of gastric juice, avoidance of biliary reflux, and decrease of intragastric pressure. And overall, patients lose weight, so this also contributes to the decrease of GERD. However, we have seen that the efficacy is not 100%. There might be some cases when Roux-en-Y gastric bypass is not efficient for the treatment of GERD. In this slide, I try to summarize the potential causes, which may be related to esophageal motility disorders, hiatal hernia, a big size of gastric pouch, the presence of candy cane syndrome, which is a redundant alimentary limb at the site of the anastomosis, which can create stasis, and thus patients may be prone to develop reflux. The treatment is quite simple. We just need to resect this part, and most of the cases solves the problem. Other factors that may contribute to post-bariatric GERD is a too short alimentary limb, or a stenosis at the jejunal anastomosis, which can create stasis and reflux. Now I would like to touch on some innovative surgical procedures in this context. When patients after sleeve gastrectomy are complaining of reflux, first-line therapy may be indicated to prescribe PPIs, and as a backup to convert to Roux-en-Y gastric bypass. However, some patients may not want to undergo Roux-en-Y gastric bypass, and for those isolated cases, we may consider implantation of electrodes to stimulate the lower esophageal junction. A pilot study came out from Bern last year, and the initial results were promising. However, I learned recently that this company producing the device has gone bankrupt. Another option may be the implantation of the links, which we also use in the general population. Here, the idea is to put a magnetic ring on the lower esophageal junction to prevent acidity reflux. When I spent a year as a resident in Paris, Professor Marmuse was very enthusiastic about the combination of the heel repair and sleeve gastrectomy. Here, the idea is that we use previously validated reflux surgery in patients who undergo bariatric surgery or who complain of post-bariatric reflux, and there is no necessity to perform fundoplication in this context. We should perform a posterior cruroplasty and attach the GI junction to this cruroplasty to prevent hiatal hernia later. A group from Montpellier went even further and described the Nissen sleeve operation. This can only be performed at the time of the sleeve, not as a post-bariatric backup intervention. They describe the performance of a 360-degree wrap and then sleeve gastrectomy. Problem with this procedure is that my learning curve is quite steep. There are not many people doing this operation worldwide, and there might be a concern about the devascularization of the wrap, which can lead to devastating consequences. A recent publication from Spain described the use of the ligamentum teres hepatis to perform a cardiopexy, again with the idea to prevent hiatal hernia after the operation. Just by looking at so many different ways to treat the problem of GERD and obesity same time, sends the message that this problem needs to be solved. And I also would like to emphasize that pharmacologic therapy is not without side effects. Beyond the problem of cost and compliance issues, there are some papers that describe that in patients who take long-term PPI therapy, there may be an increased risk of pancreatic cancer, or a weak but still increased risk of bone fracture, hypomagnesemia, cardiovascular diseases, pneumonia, or renal diseases. So to sum up, I think it's important to know that sleeve gastrectomy has become the most widely performed bariatric procedure worldwide. Nevertheless, the risk of GERD and Barrett is higher in sleeve gastrectomy than in gastric bypass. Therefore, gastric bypass is the procedure of choice to treat obesity and GERD at the same time. And in patients who develop post-bariatric GERD as a first-line therapy, we should consider PPI treatment, and as a backup, a conversion from sleeve to bypass together with cruroplasty is also legitimate. Thank you very much for your attention. I'm happy to take questions.
Well, thank you very much for this nice presentation. Are there any questions from the audience? Comments? Yes. Why I'm not surprised.
Thanks, Daniel, for this excellent talk. Just a technical remark. With the pH meter, you don't exclude biliary reflux. You just measure the acid.
Yeah.
But you can't really measure bile. Therefore, you need the Bilitech device, which is not used widely. And with impedance, you can have an estimate of non-acid reflux, but not biliary, because you don't measure the bilirubin as a marker of biliary reflux. The other thing is, I was wondering, how do you deal with precancerous lesions in the distal esophagus when you have Barrett's metaplasia, short segment, long segment, when you have dysplasia, so low-grade or high-grade dysplasia? Would this be a contraindication for bariatric surgery? Because you have an increased risk for developing an esophageal adenocarcinoma, and this could be difficult to treat during the further course of the patient.
That's a tricky question, and it's a rare situation. We rarely see that. That would have to be discussed interdisciplinary. I have to say, I wouldn't just go for a bariatric operation. What I certainly wouldn't do is a sleeve gastrectomy for the reasons that Daniel mentioned, because if you do a sleeve gastrectomy, you lose all, or the obvious chances for reconstruction. If you have someone with severe obesity who then would have a high operative risk, even for an esophagectomy, it might be wise even to do a gastric bypass and ensure regular follow-up of that lesion by half-year or annual endoscopies, and then get him into a lower BMI range, which makes it technically easier later on to do an esophagectomy even. Because then you still have the stomach remnant for the reconstruction.
Because for a classic anti-reflux surgery in patients with Barrett's esophagus, we have quite a clear way how to proceed, because we don't perform anti-reflux surgery in patients who display dysplasia, okay, because the risk is too high. In patients with a simple non-dysplastic metaplasia, so a Barrett's esophagus, there can anti-reflux surgery can be absolutely beneficial. Yes, and another question is how do you deal with the different types of hiatal hernia? You have type 1, the sliding hernia, you have also paraesophageal hernias. When do you perform simple hiatoplasty with stitches? When do you put in additional meshes? What kind of meshes would you use? This is quite a difficult question, I'm afraid, because even in the standard situation when operating hiatal hernias, this is not really clear. There's no clear rule how to proceed, but what is your experience?
I would like to start with a comment on this dysplasia metaplasia comment that you made. To the best of my knowledge, the fundoplication does not reduce the risk of development of metaplasia to dysplasia. So you can do an anti-reflux procedure, but it does not lower the risk to develop esophageal cancer. And although that is, reports on case level, to my knowledge, the gastric bypass is the only operation where there are reports that a Barrett metaplasia can be, gone into remission and is not being found. Whether that is due to some endoscopic way of looking at it, that might be. But at least there are some reports that you can, turn the course of that disease, which is not true for fundoplication. If you talk about hiatal hernias, I have to say that the experience in the context of bariatric surgery with higher Hill classified hiatal hernias is limited. We rarely see paraesophageal hernias. Usually we see sliding hiatal hernias, as Daniel has shown. And, in the 10 years I'm here now, I have not witnessed one case where this hiatal hernia was so big that a mesh would have been necessary. So our usual approach, because that is due to the regular size of this hiatal hernia, is to do a chororrhaphy. If you do a sleeve gastrectomy, you definitely have to do it, even in the smaller hiatal hernias. With the gastric bypass, it's not that clear. If you have a very small hiatal hernias, there are many surgeons who advocate to do nothing, because by having that traction on that pouch through that gastric jejunostomy, you automatically reduce that hiatal hernia. I'm not sure whether that is true, but data are scarce. But the bigger the hiatal hernia is, at least in our service, we have the approach to take care of that too with the chororrhaphy.
Thank you very much. I like the data on showing the differences in a small country like Switzerland, where there's more sleeve gastrectomies in the German part than in the French part. Are there any reasons for that? Are there more surgeons in the German part doing these procedures than in the French part? Because somehow we have the feeling that a sleeve gastrectomy is the easier procedure, even though it might not really be the easier procedure.
Thank you for this question. Actually, this is exactly the questions that we were asking ourselves when we prepared this abstract submission last month for the ESA. And based on the available data, there might be some influencing factor related to the demography of the patients. Male sex was a factor that was favoring sleeve gastrectomy. Extremes of ages was another factor. So patients between 10 and 19 years old and over 60 years old, the higher odds to have a sleeve gastrectomy. Those patients with a metabolic comorbidity, including diabetes, hypertension, hypercholesterolemia, also higher odds to have a sleeve gastrectomy. and patients with a non-private insurance had a higher odds. But clearly the highest influencing factor was the linguistic region, and we don't exactly know why. It's probably related to the patient's desire or the influence of local social media communities or the local practice of surgeons.
Yeah, did you look at the demographics of the surgeons?
This was not possible in this database, unfortunately, because we got it from the governmental database, which is anonymized, and we had only access to the domiciliation of the patients, but not the location of the center.
So we don't have that data, but it's tempting to speculate. You know, I mean, there are several data out there advocating one or the other procedure if you have that comorbidity or that factor, but it's obvious that all these factors are overruled by personal preferences and that, you know, personal preferences of the patients or even of the surgeons.
This topic has been investigated in the US, and what they found is that bariatric practices are quite monosynaptic. There are those who perform mainly sleeve gastrectomies and other mainly gastric bypass, independently of the comorbidities of the patient.
Good. If there are not more comments, I think we can close. Thank you very much.
Thank you very much.